Every year, thousands of women over 60 leave their mammogram appointment with a clean result. Normal. All clear. See you next year. And they walk out believing they have done everything right. They have been responsible. They have been proactive. And some of them, not all, but some, are carrying a cancer that the mammogram did not find. Not because the mammogram was wrong, not because the technician made an error, but because nobody told them the one thing about their own body that would have changed the conversation entirely. I am Dr. Alan Miller, and after 18 years specializing in senior health and wellness, I have watched this gap cost women their lives. Not dramatically, not all at once, but quietly, in the months between a clean mammogram and a diagnosis that arrives too late. And the reason it keeps happening is not negligence. It is a combination of time pressure, outdated guidelines, and a piece of information about your breast tissue that your doctor may know, but has simply never found the moment to explain to you. By the end of this video, you will know what that information is, why it matters more after 60 than at any other point in your life, what the specific screening tool is that can find what a mammogram misses, and exactly what to say to your doctor at your next appointment to make sure you are not walking out with false reassurance. Before we go any further, this video is educational. Everything I share today is grounded in peer-reviewed research, but it does not replace the guidance of your own physician. Please bring what you learn here into your next medical conversation, rather than making decisions independently. Let me start with something that most women were never told, and that changes everything. Breast density. Your breasts are not composed of a single uniform tissue. They contain a mixture of fatty tissue and what is called fibroglandular tissue, the functional tissue made up of milk ducts, lobules, and the supportive connective structures around them. The ratio of these two tissue types varies enormously from woman to woman, and that ratio is what determines breast density. Women with a higher proportion of fibroglandular tissue are classified as having dense breasts. Here is why this matters, in a way that is not theoretical or academic. It matters in two distinct and compounding ways. First, dense breast tissue looks white on a mammogram. Cancer also looks white on a mammogram. Fatty tissue looks dark, nearly black, which means that a small tumor hiding in fatty breast tissue stands out clearly. But a small tumor hiding in dense breast tissue is, in the language of radiology, obscured. It is white hiding in white. This is not a flaw in the technology. It is a fundamental limitation of X-ray imaging when applied to dense tissue. Studies have consistently found that mammography misses between 20 and 40% of cancers in women with extremely dense breasts. Second, and this is the part that is even less widely known, dense breast tissue is itself an independent risk factor for breast cancer, not just a masking agent, a risk factor. Women with extremely dense breasts have approximately 4 to 6 times the breast cancer risk of women with predominantly fatty breasts. This is a risk elevation comparable to having a first-degree relative with breast cancer. And yet most women have never been told their density category, let alone what it means for their actual risk. Now let me tell you about Evelyn. Evelyn was 62 when she came to see me following a routine mammogram. The result had come back normal, and she was relieved. She felt a lump approximately 4 months later and went back immediately. This time, the imaging told a different story. She had a 2-centimeter tumor that had been present, her oncologist believed, for at least a year, possibly longer. It had been invisible on the prior mammogram. When Evelyn asked why it had not been found, she was told for the first time that she had heterogeneously dense breasts, category C on the 4-point density scale. This information had been sitting in her imaging reports for over a decade. Nobody had ever explained to her what it meant, or that it changed the value of the mammogram she was relying on to protect her. Evelyn's outcome was ultimately positive. Her cancer was caught at a stage where treatment was highly effective. But she was furious. Not at her doctors, who she understood were stretched and operating within systems that do not always allow for the fuller conversation. She was furious that the information had existed all along and had simply not been communicated. That conversation, the one Evelyn never had, is the one this video exists to give you. So what is the screening tool your doctor may not mention? It is called breast MRI, and for women with dense breasts, particularly those over 60 with other risk factors, it is the single most sensitive screening tool that exists. Breast MRI uses magnetic resonance imaging with a contrast agent to visualize breast tissue in a way that is not limited by density. It sees through the white. Tumors that are completely invisible on a mammogram, hidden in the dense tissue, smaller than a centimeter, years before they would become palpable, are detectable on MRI. The sensitivity of mammography in women with extremely dense breasts is approximately 40 to 50%. The sensitivity of breast MRI in the same population is approximately 75 to 90%. That is not a small difference. That is the difference between finding cancer and not finding it, between stage 1 and stage 3, between a lumpectomy and a mastectomy, between treatment that is curative and treatment that is palliative. Stay with me, because I need to address the reason your doctor may not have mentioned this, and it is not the reason you might assume. Breast MRI is not mentioned for several interconnected reasons, none of which have anything to do with its effectiveness. First, it is expensive. The out-of-pocket cost can range from several hundred to over $1,000 depending on your insurance and your location. And insurance coverage for screening MRI is inconsistent and often requires documented high-risk criteria that many women do not formally meet, even when their actual risk is meaningfully elevated. Second, it requires intravenous contrast and a longer procedure time than mammography, which makes it less scalable in a standard clinical workflow. Third, and perhaps most consequentially for how medicine actually operates, the major screening guidelines have historically been written around population-level metrics rather than individual risk profiles. Guidelines from organizations like the American Cancer Society and the United States Preventive Services Task Force are designed for average-risk women. They are statistical documents. When your doctor follows them, they are practicing guideline concordant care. But guideline concordant care for the average woman and optimal care for you personally are not always the same thing, particularly if you have dense breasts, a personal history of certain benign breast conditions, a family history of breast or ovarian cancer, or if you were exposed to radiation therapy to the chest before age 30. Let me tell you about Helen. Helen was 68, and she had none of what she considered risk factors. No family history, no prior biopsies. She was a healthy, active woman who had never missed a mammogram in 20 years. But at a wellness appointment, I asked her something her previous doctors had apparently not asked. Had she ever been told her breast density? She had not. She did not know what it was. I pulled her last mammogram report. She was category D, extremely dense, the highest category. Her mammogram sensitivity, given that density, was likely below 50%. She had been receiving a screening that was essentially a coin flip for the tissue type she had, and nobody had told her. We discussed supplemental screening. Helen ultimately had a breast MRI the following month. It found a 6-millimeter lesion that had not been visible on any prior mammogram. Biopsy confirmed an early-stage malignancy. She had a lumpectomy and radiation. Today, she is cancer-free. And she tells every woman she knows to ask about their density. Now, I want to be fair about something, because this video is not meant to be a wholesale indictment of mammography. Mammography remains an essential, widely accessible, life-saving tool. For women with predominantly fatty breast tissue, mammography performs extremely well. For women with scattered fibroglandular density, category B, the second tier, mammography still provides significant value, and supplemental screening is typically not indicated for average-risk women. The conversation I am having is specifically targeted at women in categories C and D, heterogeneously dense and extremely dense, who represent approximately 40 to 50% of women in the United States and who are currently underserved by standard screening protocols. There is also another supplemental option worth mentioning, particularly for women who cannot access MRI or for whom cost is prohibitive. Breast ultrasound, specifically automated whole breast ultrasound, has been shown to detect additional cancers in dense breast tissue that mammography misses. It is less sensitive than MRI, but it is more widely available, significantly less expensive, and in many cases covered by insurance following a dense breast notification. It is not a replacement for MRI in high-risk women, but it is a meaningful step up from mammography alone. Let me tell you about one more patient. Frances was 71, and she had something specific in her history that her doctor knew about, but had not fully connected to screening recommendations. She had been diagnosed with lobular carcinoma in situ, or LCIS, in her late 50s. LCIS is not cancer, but it is a marker that significantly elevates future breast cancer risk. Combined with her category C breast density, Frances had a risk profile that clearly warranted supplemental screening under evidence-based guidelines. She had never been referred for MRI. When we reviewed her history together, and I connected those two pieces, LCIS plus dense tissue, the conversation changed immediately. Frances had her first breast MRI within 6 weeks. It came back clear. But she finally had a baseline, and she finally had the screening approach her actual risk profile had been calling for since her 50s. Here is what I want you to take away from everything I have said today. You are not a statistic. You are not the average woman for whom population-level guidelines were designed. You are a specific person with a specific body, a specific breast density category, a specific family history, and a specific risk profile that may or may not be well served by standard screening recommendations. Finding out which category you fall into and advocating for screening that matches your actual risk is not demanding too much. It is the minimum you deserve. Here is your action plan. First, find out your breast density category. It is in every mammogram report your radiologist has ever generated. Your number is either A, B, C, or D. Call your doctor's office, ask for your last mammogram report, and look for the words density or composition. If you are in category A or B, your mammogram is providing good sensitivity, and this conversation is primarily about awareness. If you are in category C or D, the rest of this action plan is for you. Second, ask your doctor directly. Given my breast density, is a mammogram alone the right screening tool for me? That specific question, phrased that way, shifts the conversation from routine to individualized. It gives your doctor the opening to have the fuller conversation that time pressure often prevents. Third, ask whether you qualify for supplemental screening coverage under your insurance. Many states have now passed breast density notification laws, requiring that women be informed of their density, and in some cases, that supplemental screening be covered. The landscape is changing. But you have to ask, because the system will not always tell you without prompting. Fourth, if you have any of the following in your history: LCIS, atypical ductal or lobular hyperplasia, a first-degree relative with breast or ovarian cancer, a personal history of chest radiation, or a calculated lifetime risk of 20% or greater, ask your doctor about referral to a high-risk breast clinic for formal risk assessment. These clinics exist specifically to build individualized screening plans. They are underutilized. Fifth, Do not leave your next mammogram appointment without knowing your result and your density. Both pieces of information belong to you. Both have implications for what you do next. A result without context is not the full picture. Evelyn, Helen, Frances. 3 women whose stories are different in their details and the same in their essential truth. The information that could have found their cancers earlier or confirmed their safety more reliably existed. The tools existed. What was missing was the conversation. You have now had that conversation. Make the call. Ask the question. Know your number. Because a clean mammogram and a safe mammogram are not always the same thing. And the difference is a question you are now equipped to ask.